All right, here we are, part 2 of the endocrine system. And looking it over, it looks like 3 glands here. Parathyroid glands, which sit behind your thyroid, and then your adrenals and your pancreas. So we're gonna hit these right now. All right, so the thyroid makes up most of this gland right here, but there's tiny little glands embedded in the back. They're little, maybe coffee colored. When we dissect the thyroid, they're really hard to notice. Usually have about 4 of them, but they're critically important. They're necessary for life. If you were to remove them, you would make no parathyroid hormone, your calcium levels would drop and you would die. You need calcium for your heart to beat, your muscles to move. So little glands, and they're sitting in there and they're always monitoring your blood levels for calcium. And when your blood calcium levels drop, they release their hormone and it's going to cause you to make more. So I'll review a little more here in a second. So yes, there's only one hormone called parathormone or parathyroid hormone, PTH. And calcium and phosphorus, they're related, of course, right? Your bones, are made with calcium and phosphorus. And sometimes inversely when we look at the kidneys and what's pumped out. So histologically, you take a look at it and you recognize thyroid, thyroid, and then the parathyroid is embedded into it. Less interesting looking, but it's those cells are just measuring blood calcium. And when it gets low, they release their product. And what it does, parathyroid hormone, to increase your calcium, 3 main ways. One is it stimulates, you guys remember the cells in your bone that destroy bone and release calcium? Osteoclasts. So it gets the osteoclast going, you break down this calcium you stored in your bone into the bloodstream. It tells your kidneys, hey, hold on to calcium. So it allows you to retain calcium. Parathyroid hormone also necessary to help convert vitamin D, which will make your intestines take more out of your diet. So you may drink milk and cheese, but without vitamin D, it just goes through you. You need that to bring it in. So all these things allow you to have more calcium in your blood. So let's talk diseases. So parathyroid gland, imagine it's not working right. You're going to have low calcium levels, so hypocalcemia. And that is going to be a bad thing. And I got this in nursing and such. There's lots of mnemonics to help you remember things, lots of them. CATs, convulsions, arrhythmias, tetanus, stridor, and spasms. So these things, if you think about it, they're related to muscle contraction. If you remember studying the muscle, what causes muscle to contract? You need calcium that's stored in the sarcoplasmic reticulum. That goes out, and that's the first step in muscle contraction. So drugs that stop the heart are going to involve calcium. Too much or too little calcium is going to affect the ends of the synapse, the muscles itself, all kinds of things. So when you look at low calcium levels, you're going to see this paresthesia, means numbness, and then muscles, irritability, convulsions, heart problems, arrhythmias. Well, what can you do if you have low blood calcium? I mean, you can't just chew on some cheese and expect that to fix it, right? They have vitamin D that you can take and try to increase your calcium levels. But you want to look for the cause. So primary hyperparathyroidism, that is when you have too much parathyroid hormone. It's not being told to shut off. It's just stuck on and you're making too much parathyroid. Well, that can happen because imagine you have a tumor made of parathyroid producing cells, and you're gonna have more of them. So you have a huge population of these cells, you can't help but leak out more parathyroid hormone. Diffuse hyperplasia, so all of them can be big. Or you can have a carcinoma causing this. Now, secondary happens when for some reason, you have, even though the parathyroid hormone is fine, there's other reasons. It sends out the parathyroid hormone and your body's not reacting. If you have some other issue where it's the kidneys are failing so that you can't retain calcium, even though the parathyroid hormone tells you to, or you're not absorbing it because you don't make that vitamin D. So either you're peeing out too much, you can't make vitamin D because of some issue. You're even though you're making parathyroid hormone, it's not increasing your blood calcium levels. Yeah. And if this happens consistently, what happens is your parathyroid gland gets bigger and bigger because it keeps like, dude, we need more parathyroid hormone. We don't have enough calcium. So it keeps increasing in size to try to make more. And then if you fix that problem, you end up having hyperparathyroidism because you've got huge parathyroid glands from before when you were trying to make up for it. That's called tertiary hyperparathyroidism. Yeah, I have a little chart here. So yeah, so primary hyperparathyroidism, you've got a tumor, and so usually one of those glands gets really big, and then they can just remove that one and you're just fine actually. So it gets really big, you're gonna have lots of parathyroid hormone and high calcium levels, right? Secondary is if you have low calcium levels, but your parathyroid hormone is trying to react, and so you have high parathyroid hormone, but you can't. You're not like having this concomitant rise in calcium levels. And this is chronic kidney disease, so you're getting your kidneys can't retain the calcium or your vitamin D. Yeah. And then tertiary is you have hyperplasia where the parathyroid glands have tried to react like muscles work out at the gym. They got huge. And so you're going to have lots of parathyroid and then it's going to be lots of calcium because it's working. All right. So too much parathyroid is going to cause hypercalcemia. Yeah, too much calcium, which can have lots of issues. You're going to see, I'll show you a picture where the bones get broken down. This salt and pepper effect. You look at the skull bones, there's all these like holes in it because osteoclasts have been breaking it down because they've been listening to this parathyroid hormone. Yeah. Increased absorption by the intestine, your kidneys holding on to it. And then again, the phosphorus works opposite. So yeah, you reabsorb calcium to get rid of phosphorus. Just the physiology there. Yeah, so here's a picture of a person with hyperparathyroidism, and you see these holes in the bones. Yeah, and because you're eating them like Swiss cheese, the osteoclasts are working overtime. And as they break down bone, they spit out calcium and phosphorus into the bloodstream. All right, so how do they find this? Well, they look at blood work and you'll be hypercalcemic, I'm sorry. With a K, it's potassium. So hypercalcemia is too much calcium. Yeah, they sound similar, but they're different. And so in some cases, they find high calcium levels and there's no symptoms, but they notice it and maybe they want to take a look because symptoms could come about. So if they also do a specialized test looking for parathyroid hormone, and they find it elevated, then they have a diagnosis of parathyroidism, too much parathyroid going on. Yeah. And you need to figure out is it primary, secondary we talked about. Yeah. And now, of course, they can do this. They'll do this blood work and they'll know it. In the old days, people came in untreated and then stones, bones, abdominal groans, and psychic moans. So it's going to be high calcium levels cause psychosis issues, abdominal issues, kidney stones. If you have hypercalcemia, you've got too much calcium, you're more likely to make those kidney stones too. Yeah, and bones will be too much calcium. You're going to try to store it in your bones. All right. So here's a nice illustration showing that one of the parathyroid glands has a neoplasm in it. It's growing huge. It's spitting out parathyroid hormone. Your blood calcium levels are too high. Yep. Yeah. And if it's just that your parathyroids are, they're all just hyperplastic and get too much, they can remove them. So they'll go in, do surgery. It's easy to get to-ish. And they can remove those parathyroids. And I find this fascinating. I did some research. I didn't seen this before, but they'll take parathyroid glands, a piece of it, and they'll put it under some skin in your arm. I know, Who knew? And it doesn't matter where it is. It could be here, here, anywhere. It's just as long as it's access to the blood, it will recognize blood calcium levels. When they're too low, it will release its hormone. That's its job. Yep. All right, so parathyroids. I want to talk about them quite a bit, but they can affect your calcium levels, of course. All right, your adrenals. Very critically important glands. You need them for survival, and they secrete a lot of hormones. When you think adrenal glands, you think adrenaline, epinephrine. That comes from the medulla, from the middle. Your cortex, this rind all the way around it, is secreting steroid hormones. So they're fatty hormones with a backbone of cholesterol. And important ones, we'll talk about cortisol, and then aldosterone and sex hormones. Yeah. So a general term for these are glucocorticoids, cortisol, glucose, can increase blood sugar. Mineralocorticoids, minerals meaning sodium. And then androgens are sex hormones. Yep. And then the middle, the medulla, is actually modified neurons that are secreting a neurotransmitter, which is epinephrine and norepinephrine. So I have one picture here, the histology. So remember, this is the cortex. And you guys, of course, learned in A&P about the zona reticularis, fasciculata, and glomerulosa. And those three secrete hormones that we call salty, sweet, sex. So salty is aldosterone, sodium. That's by the outer layer. The middle layer, the biggest layer, secretes cortisol. That's a stress hormone that's going to raise your blood sugar. And then the reticularis, or the inside, secretes sex hormones, androgens. So 2 diseases. We'll talk about overproduction or underproduction. So Addison's disease is, you can see how rare it is. 117 people out of 1 million. So pretty rare, it can be missed. It's not looked for. I mean, you don't see it very often, so that's why sometimes this is not diagnosed properly. But what happens is that your adrenal cortex is destroyed and stops making these hormones. Well, guess what? You need those hormones for life, all right? So you're gonna die unless it's treated. Luckily, the treatment is they'll just replace those hormones with pills. But yeah, so you can see the adrenal cortex makes aldosterone, cortisol, and androgens, yeah. Famously, President John F. Kennedy, 35th president, had Addison's disease. Of course, he hid it because as a politician, you know, it's not good to show your weaknesses like that, but he had kind of a tan, bronze look, which comes with it, and he took hormones, so it was fine. So what causes your adrenal cortex to stop making these hormones? Well, it used to be big around the world. Tuberculosis infection will destroy it. Other infections will too. Autoimmunity, diseases where you attack your own adrenal cortex. And so you have drops in the hormone levels as more and more of your cortex is destroyed. The symptoms of not making these hormones. Yes, you're going to have fatigue, weight loss. You're going to have low blood pressure, low blood sugar, because those glucocorticoids or cortisol keeps your blood sugar high. I mean, glucagon and insulin evolve the blood sugar, but so is this cortisol, the stress hormone. And low blood pressure, you're not making aldosterone, which makes you retain sodium. So you're peeing out sodium. And so you're gonna lose water you're gonna pee a lot. It's gonna lower your blood pressure. You're gonna have less sodium in your blood. You're gonna have less sugar in your blood. Body hair, we're talking about, remember the cortex makes androgens, testosterone like things, and it's involved too with mood. So yeah, Addison's disease, you're gonna see these symptoms. And the interesting, the bronze color of the skin, the tan, is you'll see it overall, but especially you see it in the gums and the palms, the nails, some places where you see a lot of pigment. And again, this is why it's so fascinating in endocrinology. The pituitary anterior makes ACTH, and that's going to tell your adrenal gland to make these hormones. Well, if the adrenal gland is screwed up, the levels of cortisol drop, your pituitary releases more ACTH. It's the signal to your adrenal gland, come on, we need steroid hormones. So ACTH is made like crazy to do this. Well, turns out melanocyte hormone, melanocyte stimulating hormone, also uses the same precursor to ACTH. The same precursor molecule. So it's kind of a spillover. Your body's making more ACTH, so it's making this chemical, and also because it's making lots of this, it also makes this, and so it has kind of a darkness to it. Yeah, interesting, huh? And again, the issue here, remember, just to throw this at you again, if you have low cortisol, low adrenal cortex hormones, it could be the adrenal gland is failing. In this case, you'd have high ACTH because your body's trying to do it. But if you have low adrenal cortex hormones and low ACTH, that points to a pituitary or hypothalamus problem, because your adrenal gland may be normal, like, dude, I'll make some if you tell me to, but if they're not getting the ACTH. But if it's the adrenal that's the problem, your pituitary is screaming at you with ACTH, trying to get you to produce it. So it could be one or the other. Yeah. So that they'll know you have Addison disease when you have low cortisol levels, and then they'll look at ACTH too to see what's going on. Yeah, and it's going to screw up your sodium because of that aldosterone, and your blood sugar level will be low all the time. And of course, it's life-threatening if you don't do something about it. Yeah. And they'll simply replace these hormones. If your adrenal gland can't make them, we got pills. Yeah. And this brings up something also, pharmacy world, is that when you take steroids, and you might say to yourself, oh, I haven't got to it yet. When you take steroids for many conditions, asthma, things like that, you often get this med pack or this prednisone pack where there's a tapering to it. Yeah. Because the deal is you don't want to take steroids and then just stop cold turkey. Because then you go into this adrenal crisis or Addisonian crisis, where if you take steroids, your adrenal glands, the more you take, the more they make less and less and less. Because like, oh, we got enough. So they just stop doing it. And so if you stop taking steroids, all of a sudden you're going to crash. And so you need to like taper it so that you take less and less, your adrenal gland ramps up production again. So you'll notice prednisone and various steroids, they're in this pack where you taper it because your body reacts by making less of it. And you don't want to just stop taking it. You want to, like, as you taper down, your body will come back to making more again. All right, what if you make too much, especially cortisol? You make too much steroids from your adrenal gland. It's called Cushing's syndrome. And you can see normally it's 13 per million, so it's pretty rare. But there's a lot more of it now. Remember, look at this, I love it. Iatrogenic means that we cause it, the healthcare system. So because we give steroids for so many conditions, because it's a great drug. It depresses your immune system, depresses inflammation. So steroids work great, but we don't want to be on them for a long period of time because it causes high levels of that, is this Cushing's syndrome. And that's a characteristic look. You have this obesity that's particularly this hump, this moon face they call it, in the midsection. The skin looks bad. These striations and bone issues, clotting issues, all these things. The reason why, your skin issues, things like that, is that when you have too many steroids, it depresses the immune system and it increases your blood sugar levels, but at the expense of amino acids. So if you're not using amino acids, if you're using amino acids for your sugar, you can't use them to make antibodies for infection. You can't use them to make collagen for your skin. So the problem with having excess steroids is that it causes gluconeogenesis, where you make sugar from proteins. Instead of using those proteins to make antibodies and to repair yourself. So steroids are going to lower your inflammation. So it's going to bring down that swelling, and it's going to raise your blood sugar, but it's going to stop you from healing properly and cause you be open to infections because it's using those proteins in an emergency fashion for sugar to keep you alive instead of for repair and for antibodies. Yep. So you can see characteristic, this person had the issue resolved and the symptoms took care of themselves. Another view, yeah. Someone with Cushing's. So you'll see this kind of, this weight gain, this kind of look, and then it's a hormonal problem that you have too much corticosteroids. Yeah. Patients develop diabetes from high blood sugar because they're not breaking down carbs, they're breaking down amino acids and fats to get this high blood sugar. Yep. So you're going to have hypertension. Remember, if the whole cortex is going, you're going to make more aldosterone too. That's going to have you retain sodium, bring up your blood pressure. You're going to make more androgens, so possibly more hair, things like that, and it's going to screw up your menstrual cycle if you're making more androgens too. All right, so usually this Cushing develops, and almost nowadays it's going to be because we're taking steroids. Too many steroids causes Cushing syndrome, yeah, instead of it being another cause, yeah. And I just put in here, I mean, the book talks about, yeah, that you may say to yourself, well, we should give less steroids because it causes Cushing. Well, steroids work really well for a lot of conditions. So they're good drugs. They really cause a lot of shrinkage of inflammation and other issues. And so we still use them, but chronically, to be on long term, it's going to cause these Cushing issues. All right. What about the medulla? Well, I'll talk about two kinds of tumors in the medulla that can cause too much or epinephrine problems, adrenaline problems. So this one, see, pheo means dark, chromo is color, cyto means cell, tumor, oma. So this means it's a tumor that causes the cells to become darkened. That's where the name comes from. It's a big old name. And it's going to be a neoplasm of the cells in the medulla of the adrenal glands, which are going to cause lots of adrenaline to be secreted. And it can happen in these periodic bursts that are dangerous, where all of a sudden, you guys have felt that adrenaline rush? Well, yeah, imagine that, like, I was going to say on steroids, what's going to confuse things. Imagine like that big adrenaline rush happening. And even when they do surgery, they got to watch your blood pressure, because if they go in there and squeeze it, you're going to have this rush of adrenaline. So they need to be careful. So it can lead to heart failure, high blood pressure, if you're making too much adrenaline all the time. So they'll notice this type of tumor. And this one happens in kids. This neuroblastoma is going to happen in children. And you're going to have, it's another malignancy or neoplasm of the neural crest cells. So neuroblast, blast kind of being a cell, an early cell. Yeah. So it's a tumor of the cells. Yeah, and it happens in children. It's going to make too much adrenaline. All right, and finally, let's get to the pancreas. And not all the pancreas, because 90% of the pancreas secretes pancreatic juice, which goes into your duodenum, right? We talked about pancreatitis in an earlier lecture. Gallstones can even block that pancreatic duct, right? Now we're going to focus on the little tiny islets, tiny proportion, the endocrine portion of your pancreas. And they secrete various hormones. The most importantly is insulin and glucagon. So beta cells secrete insulin. And that is going to be secreted after a meal to help lower your blood sugar. Between meals, glucagon is secreted. It's going to cause you to break down glycogen and release it to have more glucose in your blood between meals. Somatostatin, I won't talk about that. It's inhibitory. Yeah, and so you're going to see type 1 diabetes is when it's going to be autoimmune, where it attacks beta cells and destroys your beta cells. Thus, you make less and less insulin, means your blood sugar is going to rise and be uncontrolled. Exactly. So the blue is normally your blood sugar is below 100. And you can see once you lose that control, pre-diabetic, and a diabetic, it's always high blood sugar. And after a meal, it skyrockets dangerous levels and doesn't lower. Now, if you took a shot of insulin here, then it would lower, right? But you don't make that normally. So a diabetic can't control that. So diabetes mellitus, it's not insipidus, completely different. This means sweet. And so they used to diagnose this by tasting the urine. It's sweet. Yeah, because there's sugar in it. Only because you have so much blood sugar that your kidney tubules they reabsorb sugar, glucose, but they get overwhelmed and you end up with sugar making its way into the urine, where in an average person, you would take all that sugar because it's valuable. And with it, you pee more too, because if there's more sugar in your urine, osmotically, it's going to take more water with it too. Yeah. So with diabetes, you guys know, God, we've talked about already a lot of these things, the way it causes retinopathy. Remember, it can cause blindness. It causes the nerves, because the blood vessels in the nerves, and peripheral neuropathy is very common. And all of your arteries. It's high blood sugars. We're not sure exactly how, but it really is tough on blood vessels, the small ones and the big ones. Yeah, and so it's tough on blood vessels. Yeah, this high blood sugar. Prevalence, as you get older, more likely to develop diabetes. Racially, Blacks and Native Americans, high levels. Like I say, it's like 8% normally, and those groups is 15%. Some Native American population is 30%. So it's just accepted with old age, you get diabetes in some of these populations. Yeah, and it's of course increasing. I'll show you some graphs. So if you have diabetes, you have a state of hyperglycemia, too much blood sugar. Yep. And type 1 and type 2, type 1 is that you don't make enough insulin. It's usually happens in childhood, where you have an autoimmune disease, where somehow, again, these antibodies are trying to fight some other infection, but they're so similar to the beta cells, they destroy your beta cells in your pancreas. So you can't make any insulin if you don't have beta cells. Yeah. Type 2 is often called adult onset. That's when you make enough insulin, but your cells start ignoring the signal. And this is one that's really increasing, linked to obesity quite a bit. High fructose corn syrup has been thrown in there. If you have your cells become fatigued to the insulin. And just so you know, why do you need insulin? Insulin binds to cells, and it allows you to uptake glucose from the blood into the cells. And so after a big meal, you eat a bunch of sugar, you have a rush of insulin, and it takes glucose out of the blood and stores it as glycogen or as fat, just takes it out of there. And glucagon takes that stored fat and glycogen and releases it. So between meals, you have glucose. All right. So the type 1, it used to be called juvenile diabetes. You know, you're kind of born early on, you lose the ability to make insulin. Indeed. So they're very different diseases, as you can see. Yeah. Type 2 can develop over time, usually does. Yeah. Both of the treatments are insulin. You know, if you can't make it, or if your cells are resistant to it, just give yourself a lot of it and you try to like knock on the door to let that glucose in. So what causes it? You can see multifactorial etiology involving genetic and non-genetic factors. Fancy words for saying many things are involved in causing diabetes. Some of it's definitely genetic. You can see in families more likely to get it, and non-genetic factors. You know, if we could determine probably a virus, something early on with type 1 causes us to attack our beta cells. And risk factors, especially type 2, obesity, definitely. Pregnancy, you can have gestational diabetes. So it happens when you're pregnant, and then you're not pregnant, it goes away. But even having it makes you more likely to get type 2 diabetes later on. And then steroids infections, you wonder, well, how's that involved? Well, Anything causing stress, and steroids, release of stress, cortisol, is going to influence your insulin receptors. So that's it makes an effect. All right, so there's hyperglycemia. And one thing with diabetes too, you should know diabetic ketoacidosis, what we're talking about there. Acidosis means you become more acidic, too acidic, and it's deadly, right? Well, what's the easiest way to become acidotic? Hold your breath, right? So CO2, respiratory acidosis, is the easiest. Here we're talking about a metabolic acidosis. And the deal is this. Your cells want to use carbs to make sugar. They want to burn sugar inside your cells. They want to burn sugar, glucose. And if you can't get sugar into the cell because you have insulin, that glucose remains in the blood. So the poor cell has sugar all around it, but no sugar inside of it because it can't get it in because of insulin. Turns out exercising muscles, they don't need insulin. So exercise is good that way. But most other cells we're talking about, they need the insulin to get it into it. So what does the cell do instead of burning sugar? Well, it's going to burn fats. It's going to burn fats. And when you burn fats, it gives off ketones and other, ketones are acidic. And so normally you guys, you burn ketones. You're on a ketogenic diet. You're not eating much carbs, but you use the ketones for energy, you're fine. But if all the cells are making ketones, then you can get this ketoacidosis, life-threatening. Yeah. And so starvation, you're going to be, or alcoholism too. You end up not getting all your calories from alcohol instead of a normal diet. And yeah, you're going to end up with too many ketones causing your acidity to go up. Your pH to go down, remember? Acidity to go up. So long-term complications. If you have uncontrolled diabetes, you have hyperglycemia all the time. I mean, if you control it really well with insulin, then it's not going to be a problem. But when it's getting high, you're doing damage, especially to the blood vessels over time. Yep. So vascular injury is what we're talking about. And you'll see the extremities, the feet, you'll see neuropathy, but you also see blood problems, vessels that cause ulcers and skin problems. Yeah. And that's the small vessels. So this microangiopathy, small blood vessels, it's going to cause the problems, blindness, right? Infarcts of organs because it's not getting blood. Your skin and your feet, especially extremities, starts dying, necrosis, because it doesn't get any blood. But even the big vessels too, you get atherosclerosis a big time. And so the death in a diabetic is heart disease and stroke, things caused by atherosclerosis just at a younger age, because it's just hard on the vessels to be high in blood sugar. Indeed. Stroke, myocardial infarction because of atherosclerosis, blindness, the small vessels in the eye, yeah, bowel infarcts. Remember, infarct is a tissue dying because of no blood there, yeah. Definitely susceptibility to infection, and the wounds hard to heal. Sexual dysfunction too, about the blood vessels too. And then the gangrene, you lose toes. Diabetics you'll see with amputations because small blood vessels die, the tissue dies, becomes necrotic, it can cause osteomyelitis, infection going in there, so yeah. So how do you diagnose diabetes? When you guys, especially get older, they'll look at your glucose level in your blood. And if it's higher than 100 milligrams per deciliter, consistently, you got pre-diabetes, diabetes. So they'll watch you carefully, look at your blood sugar, because you want to catch it and then take medication for it, take insulin. Yeah. So again, fasting, glucose levels 100. Yeah. They can do a glucose tolerance test. They'll give you some glucose to drink, and then they'll see how much pees out later to see if it's high levels still. It means you're not being able to take it into your body. And another test called the A1C. That takes look at your red blood cells, because it turns out red blood cells, glucose binds to it. And we know blood cells live about 120 days. So your A1C looks at your average glucose levels over time. To look at glucose levels from a finger stick is immediate, but A1C gives you an average of how much glucose. If you have high blood glucose, you're going to have high levels of high A1C because a lot of your blood cells will be have a lot of glucose on them. All right. So how do you treat it? If you have type 1, that means that your beta cells have been destroyed. You're going to be monitoring your blood glucose and taking insulin after meals. There's various forms of insulin. Yeah, short-acting, bolus, long, yeah, lots of kinds, yeah. Type 2 diabetes also, same thing. But there, it turns out that losing weight and exercise really helps this. So you may avoid taking insulin altogether if you change your lifestyle and your diet and such. So if not, you go into the medication route. And there's other medications too besides insulin, a whole bunch of them. Yep, so there's ideas about islet implantation, of getting healthy cells put into you. That's not working really well, but there's future there. And then this ability, you have a glucose monitor implanted in you, and then it sends signals to an insulin pump. So if you can monitor it that well, giving insulin from this pump, oh man, you're in good shape in terms of blood glucose levels. And looking at how it's increasing over the world, you can see in what parts of the world if you eat a healthy diet, not a lot of refined sugar, there's less of this type 2 diabetes. And if you look at obesity increasing, diabetes type 2 is tracking it beautifully. So not beautifully. So what we're seeing is diabetes is increasing the world over. It's going to become a bigger and bigger problem because of our increases in obesity. All right, what about pancreatic cancer? We talked about it with cancer. It's really a deadly one. So you can have these tumors, yeah. And in this one, you can have a tumor that it's going to be secreting out insulin like crazy. So it's going to cause a huge drop in your blood sugar, hypoglycemia, because your tumor in your pancreas is making tons of insulin. So they can find that and take care of that. And there's other tumors. Again, I'm not going to get into it too much, but there's a couple kinds of neoplasms that affect several endocrine glands at once. Look at that. Parathyroids, pituitary, and pancreas. So some strange tumors that affect many endocrine glands. And then I want to talk about this. There's ectopic hormone producing cancers. Really weird. So you have a lung cancer, and you just have to realize that there's tumor producing cells, small ones everywhere. And we don't talk about this. We talk about thyroid and pancreas and adrenal glands, but your gut produces a lot of hormones. Your heart produces hormones. So many tissues do that. If there's cancer of a particular cell, maybe a lung cell that's growing this tumor, it starts secreting usually ACTH. And so you have an ectopic tumor producing hormones. So you may notice a hormonal level. Oh my God, your pancreas is fine or your adrenal gland's fine. It's this tumor that's producing all these hormones. And paraneoplastic syndrome is going to be hormones produced by a cancer, a tumor. Yeah, it's really interesting. And you can see all these, I just put this on there, interesting, look at that. So you can have different cancers that produce different hormones. So you may look at the gland like everything's fine, it's this tumor. All right, finally, to have failure, we talked about with your pancreas. If you're not making insulin, you've got to just replace it. So some of these, of course, are lethal. You need adrenal hormones, steroid hormones. You need pituitary hormones. And so if you have failure of that gland, you're going to have failure of life. Yeah, access to insulin, a human right. Yeah, it's interesting. Some people, because they can't afford insulin, are rationing it, or not taking it, and causing death. So yeah, to think that people will have to do that because of money is sad in this richest country too. Yeah. All right, 2 lectures. We covered a lot of issues with endocrine issues, usually overproduction, underproduction, or tumor. All right, I think we're looking good here.